In today's video, we're going over the clinical examination of patellar tendinopathy. So Tyler, is your pain right here?
Yes.
Congratulations, patellar tendinopathy. That's the end of this video. Okay, so kidding aside, patellar tendinopathy clinical examination is pretty dang straightforward. However, there are a few things you need to keep in mind when you're doing your diagnosis of these patients. My name is Dan, I run Fitness Pain Free. I am a physical therapist and a strength coach, and we have helped thousands of clinicians through our courses, communities, and mentoring programs. My goal today is to make you 1% better. Let's do it. First of which is going to be the population. So patellar tendinopathy is going to be more common in males compared to females. It's also going to be common in jumping sports. The biggest sport is going to be volleyball, followed by basketball, but really any sport requires some sort of jumping or running, you're going to see this. You're also going to see more patellar tendinopathy in higher volume athletes. So if an athlete just has more sports participation, they're more likely to have patellar tendinopathy. The last thing you're going to find is that there's a higher incidence of patellar tendinopathy in folks that play in a higher level of sport. So if you have a pro basketball player, they're more likely to have patellar tendinopathy than a recreational basketball player. Next thing to look at is going to be the location of symptoms. So Tyler has graciously donated his knee to science. This is a permanent marker, it's never going to come off. So thank you very much, Tyler. So folks that have patellar tendinopathy or quadriceps tendinopathy, you're going to have pain in one of two locations. So A, you have your quad here, comes down into a tendon right above the kneecap. So essentially, where we have this red here, that would be quad tendinopathy. And you also have patellar tendinopathy, which is going to be below the kneecap in red going down, right? Basically what we're doing is we're finding the kneecap, we're going to the very bottom called the inferior pole right here, and we're also going down to the tibial tuberosity, which is right here. So I've drawn it here in red. Generally speaking, the majority of patients are going to have pain in the inferior pole of the kneecap or the patella. About 65 to 70% of patients are going to have pain there. About 5 to 10% of patients have pain right on the tibial tuberosity. Keep in mind, sometimes these folks may have Osgood-Schlatters. We'll talk about that in a minute. And about 20 to 25% are going to have symptoms above the kneecap on the quad tendon right here. Another thing that's often missed as clinicians is making sure that you palpate that like button and also palpate the subscribe button. Next, we'll chit-chat about differential diagnosis. The one most common differential diagnosis you'll see is probably patellofemoral pain. So patellofemoral pain from a location standpoint is usually not directly on the quad tendon or the patellar tendon. Oftentimes, patients with patellofemoral pain will complain of some diffuse pain somewhere that's underneath the kneecap, around the kneecap, maybe that's on the outside or their inside, but usually they can't put one finger on that area. If someone says, yep, my pain is right here, they can use 1 to 2 fingers, and it's right on that patellar tendon or quad tendon, you're thinking it's gonna be more patellar tendinopathy. For patellofemoral pain, it's a little bit more common in females than males. Patellar tendinopathy is kind of the opposite, although you'll certainly see patellofemoral pain in males. It's more common with females. Lastly, patellofemoral pain is a little bit more common in runners, although you can get patellar tendinopathy in running as well. The next thing you're going to look out for is Osgood-Schlatters. So essentially, if we're looking at our patellar tendon, it goes down, attaches to tibial tuberosity. If your patient has pain right on this area, could be patellar tendinopathy, but could be Osgood-Schlatters. One of the differentiating factors is age. So someone is 15 years of age or younger, better chance of Osgood-Schlatters. The other piece is that in some folks, you'll notice the tibial tuberosity becomes more prominent. So if someone has pain right on this area, they're younger, and it's starting to become a little more prominent on the symptomatic side compared to the non-symptomatic side, start thinking Osgood-Schlatters.
Pardon the interruption, but I have something that's going to change your life. It's $1 million. No, it's not. But it's an evidence-based guide to patellar tendinopathy. Staying on top of literature is hard. It never feels good to have a patient in front of you with a specific condition and you haven't read through the research recently. Well, this bad boy is going to help you out. It is an evidence-based cheat sheet for patellar tendinopathy, and my promise to you is I'm going to catch you up to date with the literature on patellar tendinopathy under 10 minutes. We go over definitions, anatomy and biomechanics, differential diagnosis, risk factors, prevalence, clinical presentation, recurrence rates, how to diagnose this condition, and all the best treatments for this common problem. Best of all, it's 100% free, so go ahead and click on that link in the show notes in the description and get your cheat sheet on how to best treat patellar tendinopathy. Now back to your video.
Next, we're going to rule out a distal femoral stress fracture. We can do this with a fulcrum test. So essentially, we're going to have Tyler pick up his leg just a little bit. My hand goes underneath, and I go right on top of his opposite side knee or thigh. And I'm going to take my opposite hand, I'm going to go right at the end of his thigh by his kneecap, and I'm going to direct my force straight down to the floor. What I'm trying to do is bend the femur. And essentially, if someone has a stress fracture, it should probably hurt. What's nice about this test is it has a high sensitivity. So if we're trying to rule this condition out, it's a good option. Next, we're on the lookout for infrapatellar fat pad or Hoffa's fat pad irritation. The thing about the infrapatellar fat pad, it's going to be directly behind the patellar tendon. So basically, if you have pain right in this area, it can look exactly like patellar tendinopathy. The thing about patellar tendinopathy is it doesn't really hurt to fully straighten the leg or extend the knee. But with infrapatellar fat pad irritation, extending the knee hurts. So essentially, if I passively extend Tyler's knee, if this reproduces a patient's familiar symptoms right in that area, I'm thinking maybe the fat pad. But if no pain whatsoever, I'm still thinking it's more of a tendinopathy. Next, we always want to look out for meniscus pathology, ligamentous issues, or generally tibiofemoral joint stuff, right? So typically the first thing that teases us out is going to be the mechanism of injury. So if someone has a traumatic injury to a ligament or the meniscus, usually they're playing their sport, jumping, pivoting, changing direction. Usually they feel some audible pop or some sort of pain afterwards, and oftentimes you're going to sense a little bit of swelling within the joint. So overall, you're just going to hear a bunch of stuff that makes you think more meniscus related. The other things you can do from a special test perspective is range of motion testing. So for patellar tendinopathy, extending that knee, flexing the knee shouldn't hurt. But if I extend the knee a little bit, maybe I bounce home a little, or if I fully flex, if this is becoming painful for your athlete, you might start to think maybe this is more meniscus or something else, right? The other thing we can do is some joint line tenderness testing. So essentially, I'm taking my fingers, I'm gonna find the medial joint line, and I'm just gonna go from the patella to the side, wrapping around on the back. And hey, does this reproduce your familiar symptoms when I'm poking on this area? If not so much, then we're starting to think not necessarily gonna be a meniscus issue. I can do the same thing on the other side. So on the side of the patella, feeling all the way to the back side. And again, if no symptoms, I don't have to be worried about any issues there. Next, we'll go over some aggravating factors. So folks that have patellar tendinopathy typically have pain when we load the quad, and also something called the strain rate becomes important. So if I load a squat, right, going up and down, what happens is that I am loading the patellar tendon, I'm not loading it that quickly. If I do something like a squat jump, you mind doing one or two of those? I'm loading that patellar tendon and I'm doing it fast. So there's a higher strain rate, and you can relax for now. So two things. When we load up the quad, it can reduce pain. If we add more load, it should produce even more pain. And then we increase that strain rate, that should also elevate pain as well, right? So you can always start off with a typical squat. So go ahead and squat a few times for me, Tyler. Yep, any pain with that? Largely as we descend deeper into the squat, usually that provokes more pain. So if athletes say it kind of hurts more towards the bottom of the squat, that makes sense. If that doesn't provoke any symptoms, we can go to a single-legged squat. So show me one or two of those. Very good, so increasing the load, very good. Any pain with that right there? A little bit? Okay, good stuff. Next thing we'll do is a squat jump. Let's do about 5 of those. Go for it when you're ready. Good. One. Good. All right, pause for there. We don't need 5. Any pain with that? Yeah. A little more pain. So that's what you should notice. So basically, as we start to load, the tendon should hurt a little bit more with more challenging exercises. If you're still not sure what's going on, you can do a single-legged squat jump. Just keep in mind, this is very, very hard. So go ahead and give me a few, Tyler. Good. Ooh, painful, painful. Hurts so much, I can't even keep going. I'm just kidding, but that's what you should find. So largely, as you start to increase the speed of movement, it should be a little more painful and progressively worse as you go faster and add more load. All right, so now you know how to diagnose patellar tendinopathy, but you still need some good exercise to treat it. Well, I got the video for you. Leave a link in the corner. Go ahead and click on that link and we'll go over progressions and regressions for patellar tendinopathy. I'll see you there.